Hello everyone, today we are going to revise about aortic stenosis. Aortic valve has mainly three parts. One, the circular annulus, three leaflets and three commissures between them. Aortic valve is mostly tricuspid. Sometimes it could be bicuspid or quadricuspid. In case of bicuspid aortic valve, there are increased chances of aortic stenosis, whereas in cases of quadricuspid aortic valve, there are increased chances of regurgitation. Normal size of the aortic valve is 3 to 4 centimeter square. Now, normally, isovolumetric contraction of the ventricles takes place, then there is opening of the aortic and the pulmonary wall, and there is rapid ejection followed by slow ejection. There is no gradient between the aortic and the ventricle. Between the aorta and the ventricles, both are at 180 mm of Hg, but when there is some pathological process and the gradient develops, then there is development of the aortic stenosis. There is a process known as aortic sclerosis, which happens due to some pathological changes, but it doesn't lead to development of gradient. For example, there is a bicuspid or a tricuspid aortic valve in which due to some pathological processes like lipoprotein deposition, activation of RAS system, conversion of the myofibroblast into osteoblast, calcium hydroxyapatite deposition, the process known as aortic sclerosis happens. But it doesn't lead to aortic sclerosis, aortic stenosis. Aortic stenosis develops when there is a transvalvular gradient and then symptoms occur. Now we'll learn about valvular diseases, combination in rheumatic heart diseases. Mostly it is a MR plus MS. It could be MR plus, sorry, mostly it is MR plus MS. It could be MS plus AR or AR plus AS. 30% of the elderly people have this sclerosis in the walls, but there is no development of aortic stenosis. And this process is more common in males. Then we move on. In cases of aortic stenosis, it is mandatory to undergo coronary angiogram because atherosclerotic process is going on, so there might be some atherosclerotic changes in the coronary vessels. Most common cause of worldwide aortic stenosis is degenerative calcification, whereas in youngs it is bicuspid aortic valve. Most common valvular pathology worldwide is aortic sclerosis. Most common valvular heart disease worldwide is mitral regurgitation. Then we will learn about bicuspid aortic valve. It is due to some congenital valve defect due to mutation in the NOTCH1 gene, which leads to defective eNOS enzyme production. It is more common in males, and it due to autosomal dominant and it is associated with aortopathies like aneurysm and dissection, so it is mandatory to undergo CET aortogram before valve replacement. Then types, based on location, it could be valvular, subvalvular, for example in hypertrophic cardiomyopathy, in supravalvular, in cases of Williams syndrome, in which there is increased calcium, mental retardation and growth failure. Now, different types of aortic stenosis based on the severity. It could be mild to moderate, in which compensatory changes take place in the left ventricle. The cardiac output is maintained at the expense of the left ventricle cavity size. In this, there is left ventricle concentric hypertrophy. Then there is severe aortic stenosis. In this, there are chances of sudden cardiac death in 1% cases. In such patients, we should do aortic valve replacement. In such patient, there is a rule 40-4-1 rule. In that is, the transvalvular gradient is more than 40 mm of Hg. Peak velocity is more than 4 meter per second, and the surface area is less than 1 centimeter square. Then, in cases of very severe aortic stenosis, there is left ventricular failure and it has bad prognosis. Then we move on to symptoms. There are basically three symptoms. ASD, angina, which is due to hypertrophy of the left ventricle, which leads to increased oxygen demand due to decreased coronary blood flow due to atherosclerosis and decreased capillary density with respect to wall thickness. A person with angina who doesn't undergoes a wall replacement will have average survival of 5 years. Then syncope. It is due to fixed cardiac output status. There is no increase in cardiac output with increased activity. A person who doesn't undergo wall replacement will survive 3 years. And in cases of dyspnea, which is due to increased left ventricular and diastolic pressure, which leads to increased left atrial pressure, which leads to increased pulmonary capillary wedge pressure, and thus dyspnea is developed. Person would survive 1 year, in 2 years in absence of wall replacement. So there is 5, 3, 2 years respectively survival in absence of wall replacement. Associations with AS. The atria, in case of AS, contributes 40% of the cardiac output. So in cases of atrial fibrillation, it would be a fatal condition. Then association with hypertension. The gradient between the aorta and the left ventricle will be masked if there is hypertension. So it hypertension marks the severity of the AS. And then there is left ventricular failure in cases of severe AS, and there is a syndrome called Hayday syndrome in which there is angiodysplasia of colon and aortic stenosis. And aortic stenosis is cause for acquired wall-Williams disease. Then some findings in case of aortic stenosis. Firstly, pulse. There is pulsus tardus in which the desired amplitude is reached. Pulsus parvus et tardus in which the desired amplitude is not reached. In both the cases, pulse is slow rising. Then BP. In case of very severe AS, there is left ventricular failure, so narrow pulse pressure is seen. JVP is normal. Apex is shifted outwards due to left ventricular hypertrophy. There is a heaving apex. High amplitude sustained apex. Heart sound. First heart sound, ejection click is heard in case of bicuspid aortic wall. Second heart sound, in cases of degenerative pathology, soft. In cases of bicuspid aortic wall, loud. In severe AS, there is reverse splitting of S2 due to late A2. Then S3 is present in cases of left ventricular hypertrophy or left ventricular failure. S4 is present. Then the murmur. There is a harsh mixed frequency murmur. Ejection systolic murmur with late systolic acceleration, which differentiates it from the innocent ejection systolic murmur. There are two components. Low pitch component radiates to the carotid, whereas the high pitch component radiates to the apex. This is known as Gallagher phenomenon, and best portion in which this murmur is appreciated is aortic area. Then we will move on to investigations. In ECG, there is left ventricle strain pattern. There is a criteria known as Sokolov-Lyon criteria, in which we add up the R wave of either V5, V6 and S wave of either V1 or V2. It should be more than 35 mm of Hg. There is no much ST depression and asymmetric wave inversion is found. In X-ray, there is dilated aortic arch in AS, and in echo, definitive diagnosis is made and it assesses the severity of the disease. Treatment. Aortic valve replacement is done. Bioprosthetic valve are commonly used. Less complication, no need to continue anticoagulants. Indications of aortic valve replacement. Firstly, if there is severe symptomatic aortic stenosis, asymptomatic severe aortic stenosis, that is, there is a 50, 60, 5. These three numbers we have to remember. Ejection fraction is less than 50%. Peak gradient is more than 60 mm of Hg, and the peak flow is more than equal to 5 meter per second. Then now we are reading about the indications of aortic wall replacement. We have read about severe symptomatic, severe asymptomatic is in the three conditions 60, 50, and 5, and then rapid progression in yearly co underlying any if the person is undergoing any other procedure, and if the person is symptomatic on dobutamine stress test. It is used to differentiate very severe AS from left ventricular failure with incidental AS. Disadvantages of AVR, aortic wall replacement: first, more complications; second, difficult to get fitness for elderly patients. So there is another procedure called transcatheter aortic wall replacement done by cardiologists trained in this procedure. It's a costly procedure and can be considered when there is a contraindication for aortic wall replacement. Thank you.